Well, delighted to introduce one of our longtime supporters, Hannah Mamuszka from Albertan, and Erika Spaeth, who will be discussing Beyond BRCA, a polygenic risk score to identify it disappeared. But no, that's fine. After you, it's all up to you, Hannah.
Do you have the clicker?
Yes. Sorry, I thought I gave it to you. There we go.
Great. Hi, everybody. I think I actually know a lot of you in the audience, so this will be fun. I hope you guys can hear me okay. My name's Hannah Mamuszka. I'm CEO of Alva10. I've been in the Cambridge industry, both in pharma and diagnostics, for just about 25 years. I started my career in Cambridge down the street at Leukocyte, which was acquired by Millennium. And I've worked in both drug development and diagnostics, really through this emerging space of precision medicine. But my passion is really in diagnostics. And it's really, both on the technical side, but also what I have found to be increasingly the problem, which is how do we actually translate the amazing science we have in our labs, in our academic centers, in our hospitals, into actual clinical practice. And the barriers are often not clinical or not technical anymore. They're on the transition side, they're on the physician side, they're on the commercial side, they're on figuring out how to communicate adequately to patients, to physicians within hospital systems, and also figuring out how to get these tools paid for. So we're going to talk today about breast cancer risk and about really what the realities are and what we understand today about breast cancer risk, identifying women who are at risk for breast cancer, things we can do to prevent breast cancer from developing, and also other strategies that are emerging that give us a better understanding of the actual landscape of breast cancer, particularly on the diagnosis and prevention side. And today I'm joined by Erika. Do you want to give a little bit of your background?
Yes, sure. I'm Erika Spaeth. I'm the Director of Clinical Affairs for a company called Phenogen Sciences, and we are the US subsidiary of Genetic Technologies. And it's a biotech company that focuses on disease risk prediction. And one of the main components of the disease risk prediction is polygenic risk, which really helps stratify risk prediction. And part of my interest in this comes from my background, which is in tumor biology. Before I landed in the clinical commercial lab space, I did my postdoc at MD Anderson, where I researched the tumor microenvironment and was understanding how normal host cells can go from being growth restrictive for tumors to growth permissive. And I think this is one of the things that really interests me about polygenic risk. And it's so fascinating at what role it might play in this really complex interaction between the tumor and its host, but how does polygenic risk fit in? And I think when we take a step back and look at all of the risk factors that we know that contribute to the risk of developing a cancer, where does this polygenic risk fit in? And we know at this point that it is one of multiple risk factors, and even though we don't know a mechanism of action, like all the other risk factors, family history and breast density status, it's one of many risk factors that really helps clarify a subset of women that are at risk of disease and what can we do to help prevent and at least screen better for certain women. So I know I'm excited to talk more about it today.
Well, I think there's a lot of misconception around BRCA-ness, BRCA positivity, family history, and how much that actually relates to a risk of a woman developing breast cancer. And I put this up here so if you're connecting with me on LinkedIn, I put up a poll yesterday to ask the question, how many cancers, what percentage of breast cancer is related to BRCA, and then what percentage of cancer is related to familial history? Because I think a lot of women, and I'm sort of in the sweet spot of starting screening age, I think a lot of women think that if they're not BRCA positive and if they don't have family history, then they don't really have to worry about breast cancer. But if you look at the pie chart behind me, you see that that's really not true. It's a pretty small percentage of women that are BRCA positive. Only about 5% of women are BRCA positive. And then when you add in family history, you get another 10%. And so that leaves 85% of women who develop breast cancer who have sporadic breast cancer, meaning they don't have any family history and they're not BRCA positive. And based on the results of the survey from LinkedIn yesterday, that's pretty surprising to most people. They don't really appreciate the fact that the majority of women have a different risk factor, even though they may not be BRCA or have family history. And I think that's one of the things that the polygenic risk score has the ability to ascertain, figure out, is who those women are and how do we use it. The next thing, though, I want to talk about is screening. Breast cancer screening for women in the age 40 to 50 is not clear. And I've put up these guidelines back here. There are 7 different bodies that give guidelines to American women around breast cancer. They vary dramatically. The other thing that's difficult about them is it's really unclear as to who should be managing which guidelines for which group of women, because this could be coming from your PCP, this could be coming from your OBGYN, this could be coming from, if you have family history, from a genetic counselor. So how is a woman supposed to be able to manage these different types of risk? And do you think the fact that there's no clear owner within our healthcare system in terms of PCP, OBGYN, family counselor, what do you think that contributes in terms of the confusion?
It definitely adds to the confusion. You know, it's kind of hard to read, but you can see that between the ages of 40 and 50, a lot of these guidelines, except for the American College of Radiology, leave it up to the woman to decide. It says it's the woman's choice, but the woman usually relies on her doctor to help give guidance. And depending on what doctor you happen to choose, you may be recommended to start at 40, 45, 50. So it's all over the place. And I think on top of that, there is room to help make that decision, I guess, with a risk assessment to maybe clarify whether it makes sense to start at 40 or it makes sense to wait a little bit.
And what percentage of the general population gets tested for BRCA and then actually has their sort of treatment path or risk assessment affected by the BRCA testing?
Right, so the majority of women fall into this average risk category, and if you, less than 1% of the general population is actually a carrier, positive for a pathogenic variant. The majority of women don't even qualify for testing because you have to meet a set of strict standards based on your family history. So the majority of women don't get there. We're sort of at a place where some women are asking for the testing even though they don't have the family history, which isn't a bad thing, but it can also lead to a false sense of security. When you come back negative, a lot of women think they're then not at risk, but they are certainly still at risk because, as from that pie chart you saw, 85% of women that develop breast cancer developed sporadic breast cancer where they didn't have any sort of these known risk factors like family history. And even women that do have the family history and qualify for BRCA testing come back negative. And then what? Yeah, they still have a family history and they might be in a risk category where they get additional screening. But can we do something to better manage their risk? If someone has 2, 3 family members with breast cancer, but they're BRCA negative, they're obviously still at some risk. But what level and what should they be doing about it? So there's a big range where risk assessment could really add value to some of these discussions where clinicians and their patients are, I think, feeling a bit lost.
What do you think the reason for restricting BRCA testing has been? Do you think it's been more on the economic side? Because when it first came out, the Myriad test was so expensive and payers really restricted that? Or do you think it's more because we don't want to give women this false sense of if you don't have the BRCA gene, then you don't have to worry about breast cancer? Where do you think it?
That's a good question. I do think it's economic based initially. It doesn't make sense to screen the entire population when 1 in 400 women are going to come back with a BRCA1 mutation. So economically that doesn't make sense. But as these tests are getting cheaper and cheaper, I actually do think it makes sense to screen the general population for that. But knowing that the majority of women are going to come back negative, what other risk assessment can you add on the back end? And that's where a risk assessment that adds the known clinical risk factors, but then this newer polygenic risk where we have genetic markers of risk that give this incremental increase, and in some women, it's an increase enough to boost them over an actionable threshold.
So if between the juxtaposition of family history versus BRCA, what are the other currently used risk assessment tools that might indicate that a woman should either go in for an earlier mammography, maybe get a breast MRI? What are the other tools? I think there's the Gale model and...
Yeah, so there are a few tools that are around. The Gale model was developed in 1989 by the NCI's Dr. Mitchell Gale. So it's a tool that's been around. It's been used for every breast cancer prevention trial to establish a threshold of risk. So it's a very standard clinical tool. It's underutilized in practice. There are other tools that have been developed since then, the IBIS model or the Tyrer-Cuzick model and the Boadicea model and the BCSC model. And all of these models take certain risk factors, combine them together, and provide an absolute risk score. And there are two clinical thresholds that are used. There's a 5-year risk score threshold and a lifetime risk score threshold. And if a woman is above those based on any of these clinical tools, there are additional guidance for that woman, whether it's MRI surveillance or it's risk-reducing medication or it's an additional clinical visit. So there are guidelines that already exist. There are tools that already exist. The problem is they're underutilized in the clinic.
Why do you think they're, does that come back to the PCP versus OBGYN conundrum? Why do you think that they're underutilized?
Yeah, that's a good question. I think there are a few different potential reasons. When I've spoken with PCPs and OBGYNs, I think I would probably be generous to say that maybe half of them even knew that risk assessment models existed. Half of them probably didn't know that guidelines existed around risk-reducing medication or enhanced screening. They purely think of enhanced screening in terms of family history, but didn't realize that there are clinical models that actually incorporate breast density status and other risk factors. So that's one issue, sort of just the medical education at the PCP and OBGYN level. But that also kind of stems from the fact that, yes, we're talking about cancer, so oncologists are more familiar, but oncologists don't see healthy people. And so they have all this knowledge, but it's not really trickling down to their peers who actually see the general population. And how do we close that loop? Because oncologists would like the PCPs to be able to screen. But then I guess the other issue is our healthcare system. And the PCPs and OBGYNs have a few minutes with their patient to talk about a whole slew of things. And is breast cancer even on their radar? Maybe not when they want to touch on cardiovascular health and type 2 diabetes and all the other potential diseases. So yeah, it kind of gets pushed to the wayside.
You mentioned risk-reducing medication, and I just wanted to, so I've spent a long time in oncology. I started my career at National Cancer Institute. I've worked in oncology drug development. I've done oncology clinical trials. I've worked in the whole space. Until Erika and I started talking a few months ago, I was not aware that guidelines suggest that for women who are at high risk that they could be pre-treated with risk-reducing medication to prevent breast cancer. And I think it's really, now I've talked about this to a lot of women, including women who I know who are at high risk. And, I wonder why we're not presenting this. I wonder why PCPs are not educated on this. And I wonder why there's a reticence to present this to women as a potential ability to reduce their risk of breast cancer. It may not be for everyone, but if you found out you were at high risk for breast cancer and that you could take medication, endocrine therapy, which is commonly used to prevent the return of breast cancer after you've been treated. It's not without side effects potentially, but why do you think we're not even able to have that conversation?
Yeah, I think there are probably a few different potential reasons. One, again, is sort of the disconnect between the oncology side and the PCP side. Oncologists sort of think of this medication as, I mean, I don't want to say like M&Ms, but it's common. It's commonly used. It's not really scary, but then you talk about that with PCPs and OBGYNs, and they're like, oh my goodness, chemo prevention, that sounds really scary. I don't want anything chemo in my healthy population, which is one of the reasons they changed the language. They don't call it chemo prevention anymore. They've changed the guidelines to say risk-reducing medication to try to take away that scare factor. It hasn't helped too much yet. When the guidelines first came out, so there are 25 years of clinical trial data showing the benefits of this risk-reducing medication. So there are numerous clinical trials. It reduces a woman's risk by anywhere from 35 to 65%, depending on which medication, a SERM, a selective estrogen receptor modulator, or an aromatase inhibitor. So there's strong data. Yes, there are side effects. Side effects typically are one of the major things that a PCP or OBGYN first comments on. It says, well, you know, I have a healthy woman. I don't want to give her hot flashes. What about the risk of endometrial cancer, risk of pulmonary embolism? Yes, those are minor side effects, but they can also be carefully monitored and controlled for. So the side effects are kind of blown out of proportion almost in the PCP's mind. And once the PCP or general practitioner is afraid of offering something, they're not going to recommend it to their patient, and their patient's never going to know about it. And that seems to be where we are now.
Yeah, it definitely does. Because no one I have spoken with has ever heard of this concept, yet it's so clearly evidence that we could potentially prevent a decent percentage of breast cancer if we were actually to appropriately risk stratify women and maybe recommend this therapy. It wouldn't be the choice for all women, but it would certainly be the choice for some.
Yep.
You know, the other problem that we have in the US right now that's relating more and more to cancer is our obesity problem. And I just wanted to touch on the impact of obesity in breast cancer, because I don't know that the general populace realizes the relationship between obesity leading to higher rates of what are termed the obesogenic cancers, which is a group of 12 cancers that are shown to be more highly and tightly correlated with elevated BMI, uncontrolled blood sugar. And in breast cancer, that's also true in the postmenopausal women. And how does that factor in to assessing risk for breast cancer?
Yeah, it's definitely an important component, especially, as you mentioned, in the postmenopausal. Obesity or high BMI has an interesting relationship in breast cancer. It's actually sort of protective in premenopausal women, but that flips once you hit menopause. And you know, we do have a large percentage of our population that have higher than average BMIs, and that does impact a woman's risk. And again, there's, especially in what we call sporadic cancers, there's not one single driver of tumor formation in cancer. And so in these risk assessment models, integrating things like the BMI with all the other risk factors, they're all small incremental additions to risk, but they do start to make a big difference when you have a woman with several of these slightly elevated risk factors and you combine them all together, you push a woman over a threshold. And that's where, you know, we have almost every woman at the age of 50 considered general population, when we know that's not true. And we have about 20% of that population that would actually be over an actionable threshold if we actually assess their risk.
So let's see. All right, there we go. So this is an example of how we think about risk today, which shows 1 in 200 women have the BRCA gene, are considered to be at elevated risk for breast cancer. But if you actually used a test like GeneType, this is what you would see, which is how many women are truly at risk for developing cancer. And the majority of those women have no idea that they're at elevated risk. So do you want to talk a little bit about GeneType and how implementation of that type of a polygenic risk score would impact how we would find and treat these women?
Yeah. So 1 in 200 women will have some kind of high or moderate penetrant mutation. That level of risk is high, and that's an important population of women to sort out. And yes, there are screening guidelines and there's risk-reducing surgery for certain women. But as you could see from that previous slide, it's rare. It's not prevalent in the general population. But when we are able to look at the general population after we weed out those women that do have the hereditary risk, the rest of the population that we clump into the general population is not actually all general population. And so when we're able to pull out risk factors like the polygenic risk that can really stratify women and pick out women on the tail end that have this elevated risk, and then you combine it with breast density, which we know is a significant risk factor. But half of all women have dense breast tissue. So yes, it's significant, but it doesn't narrow down your population that much. It happens when you start combining these risk factors, so menopausal status and age at parity, or if you're parous at all. And there are a combination of different risk factors that we can put together. And then once we do that, we actually see about 1 in 5 women that are at a risk level that is actionable based on current guidelines. So current guidelines that have been set for 20 years have risk thresholds that we know about. We have risk-reducing medication, we have MRI. We already know what to do, but we're not necessarily identifying them. And I think one thing to point out is these 1 in 5 women, yes, they're over a threshold. It doesn't mean their level of risk is equal to that of a BRCA1 carrier. But they are at an elevated risk where we currently think there's something we can do about it. So we should take action if we're gonna stick with those thresholds. I guess we could talk about whether we need to change those thresholds, but that's a whole nother discussion.
Well, I mean, because current guidelines change that women have to be informed now that they're classified as having dense breasts. That came last year, I think, or this year.
Yeah,
COVID
so
has blended the
a number of different states already have laws set. There are a few, I don't know, 10 or 12 states that are stragglers that don't mandate that. But a federal mandate was put out a few years ago. I don't know if it's actually been implemented yet. I know that the FDA and federal legislation sort of lags behind, but it's on everyone's radar. Breast density notification does happen in the majority of states. So a woman gets a letter saying, you have dense breast tissue, you're at higher risk of breast cancer, and that's it. And what are you supposed to do about that? So it's the woman sort of sits there and says, okay, I guess. And the doctor sits there and says, oh my goodness, maybe I should do something about it. But there are no guidelines around what to do. So you have some doctors that do say, yes, I need you to get supplemental screening, and some doctors that say, I don't know what to do, so I'm just gonna push this into your file and not think about it.
And so but then you go into that cycle of, because I have women in my life that this has happened to, where they go for a mammogram, they have dense breasts, they get sent for an MRI, it's inconclusive, they get told to come back. And there are only so many times you can go around that cycle before you say, well, if you're not gonna tell me anything new, I'm not gonna do this anymore, because you're not giving me anything actionable to do. And you do wonder how many women you lose who fall off the screening train at that point because they don't really have any way of telling if they're actually high risk or not, and if it's worth it for them to be going in for the 6-month mammography or 6-month MRI, because it's painful and it takes time out of your schedule, and it can be expensive because everything has a copay. And if you don't have any, if you don't have an additional test that says you are actually, it's not just that you have dense breast, but you actually have an elevated risk of breast cancer, like it seems like that would be an easy way to fall off for compliance. In addition to the fact that, mammography compliance varies widely by geography in the US. Believe it or not every state Medicaid agency covers breast cancer screening, and not everyone covers mammography or doesn't cover it on the same schedule. So access to mammography, which is sort of just the gating tool that we use right now into breast cancer screening, isn't the same for everyone. And where this really shows up is in later stage diagnosis of breast cancer. We know that breast cancer is much better treated when we can find it earlier, when we can surgically resect it or treat it earlier. But when we don't use the tools that are available, whether they're risk assessment tools or mammography or MRI, and we don't screen these women, what happens is you see it pop up later with much more expensive treatments and targeted therapies. And we've had insurance companies complain about the high cost of treating late stage breast cancer when they don't really advocate for screening in the early stage, and they don't seem to see that connection. But it seems like they would benefit too from considering how to, maybe triage the use of frequent mammography and MRI by using a risk assessment tool to actually figure out who actually needs that type of imaging testing on a more frequent basis, because the compliance for everyone doing it, I think, is going to be a challenge too.
Yeah, definitely. And I think there is already, you can even have women that are suggested to have supplemental screening, but even the compliance on following through with that supplemental screening is low. Excuse me. And so a risk assessment model to incentivize a woman to follow through with that supplemental screening, just saying, look, you are at high risk because of these factors, follow through. It could be beneficial to just help increase the compliance.
So if we think about sort of three groups of risk of breast cancer, where you have your BRCA positive women, you have your, I'll say BRCA negative, but family history, and then you have your polygenic risk. What is the guidance for women who are BRCA positive as far as what they should do? I mean, I think the Angelina Jolie story is probably the most notorious and probably the most aggressive example. But there's a continuum of recommendations for BRCA positive women.
Right, there are. There are increased screening depending on what age the woman knows that she's positive. There are different screening guidelines. There is the risk-reducing surgery, but even that, so the BRCA status, the location of the mutation actually can dictate the penetrance. And so you can have two women with a BRCA1 mutation, and one has a much higher lifetime risk of developing cancer than the other. And so that is usually taken into consideration when discussing risk-reducing surgery. So there's a lot of individualized care just based on that carrier status. And then you go into the family history, and that individualized care really drops off because we don't know quite as much about it. Well, I take that back. We do know more about it, we're just not utilizing it. So this polygenic risk piece actually can really help stratify both the family history population and women without family history. And then other risk factors that are additive on top of that, because these are all independent risk factors. And so each of these can really give a clue into the woman's risk. And again, there is guidance. It's similar. So you have the carrier guidance, but then you have family history, and then you have these guidance based on set thresholds. And that's the same across the board for the family history or the sporadic. Once you're over that threshold, there is guidance on additional screening and the risk-reducing medication.
So that's pretty much the extent of it, though. Like for women who have a significant genetic risk, they are potentially recommended for surgery to reduce that risk. But for the rest of the population, and it would work pretty well if we actually identify the women who needed to be screened more frequently and used risk-reducing medication. Do we have a sense, like if we modeled that, like what the potential implications of that would be for reduction of breast cancer?
Yes.
in a modeled world, if we didn't have the screwed up US healthcare system with all of the perverse incentives and inability to deliver care. And
Right. Yeah. I mean, there have been lots of modeling papers showing if you actually put even the Gale model. So the Gale model about 10 years ago, maybe longer, came out with a paper looking at the US population and saying, look, if you utilize this model across the entire population of that were eligible 35 to 70 or so, and you'd identify this certain percentage and you put them on risk-reducing medications, you'd prevent 55,000, 60,000 breast cancer cases a year. So there are modeling studies. There is data showing, the clinical trial data is very clear on the prevention capabilities, reducing a woman's risk by 30, 40, 50, 60%, depending on the medication she's on, is significant. And it's higher than the aspirin or statins for other diseases. That level of risk reduction is higher than those medications, and those medications are given out frequently without much thought. So the level of advocacy behind some of these drugs, and part of it slightly cynical, but maybe due to patent issues. So right when these first guidelines came out in 2000, tamoxifen and examethasone were still patented. And so drug companies were going out and pushing the Gale model and pushing their drugs. And we had over quite a few number of women on these risk-reducing medications. I think there's one study on tamoxifen, maybe 160,000 women were on tamoxifen right when the guidelines were first published, because the first clinical trial data came out saying, look, this is a good risk reduction medication. And then the patent expired, and 5 years later, that number had dropped by more than half of the number of women, because the pharmaceutical companies weren't going out and actually pushing the drug and risk assessment onto the doctors. And so it slipped to the back of mind for a lot of doctors, and I think it's continued to go downhill since. And right now we have 0.2%, I think, uptake of chemo prevention right now, which is really dismal considering how beneficial it actually could be in reducing our breast cancer incidence in the US, which is 260,000 cases per year.
Yeah. You said that there's like 25 years of trial data. Like, roughly how many patients have been studied in this? And does it cross ethnicities and race? Because I mean, we've seen in the US that, I don't know if any of you were at ASCO a few weeks ago in Chicago, but healthcare disparity, particularly on the diagnosis and treatment side, is definitely a topic of conversation in cancer care. And the fact that there's a recognition that people are different, and that we need to acknowledge that we need different screening tools. So how many patients have been studied, and how representative is this across populations?
That is a good question. I'm not sure I know the answer to all that. I know thousands and thousands of patients cumulative across all of these studies have been studied. And I do know it's primarily in white non-Hispanic women traditionally. So that is a good question. And it's probably something that could be further addressed, especially because we do know in Black non-Hispanic women that the incidence of triple-negative breast cancer is higher. And so certain endocrine therapies would probably not be advantageous. So yeah, it's certainly an interesting question, and one that we don't necessarily have all the answers for yet.
Do you think polygenic risk will be, because I was talking with someone yesterday about a polygenic risk score in one European population versus another European population. I think it was Finnish and Estonian, and how those had slight differences even within those populations. So when you think about a broad polygenic risk score, how do you think about do you think we'll have multiple modules of a test?
I do. I think it's leaning in that direction because there are ancestral differences that we can pick out. And it really comes back to the population size available for the study initially, to be able to pull out these small differences. We already know a few specific differences in Asian populations and Hispanic specific populations and Black non-Hispanic populations. So we already know certain loci that confer more risk in certain populations than the others. And oftentimes the risk is actually flipped. So you can have the same SNP location, but different ancestries, that risk effect is flipped. So there are certainly ancestry specific indications long-term that I think we can better stratify people's risk. Right now, we're probably sort of at the tip of the iceberg in terms of we found some major red flags, major markers that indicate risk, and I do think that can be improved upon, especially in breast cancer where you have multiple subtypes. And so when you actually get more granular, you probably have a signature for an ER positive, PR positive disease versus an ER negative disease versus a HER2 versus a triple negative. So I do think you could probably get to a more granular level.
Oh, that's fascinating, because then you could really target specifically who should get endocrine therapy.
Yep.
Not just as a generalized risk assessment.
Exactly, and as other therapies that we know work post-cancer diagnosis, those could potentially be brought forward as prevention strategies.
Fascinating. Well, I know we're getting closer on time. I didn't know if you had, I have a couple more questions, but I didn't know if anybody else had any questions, particularly for Erika and her expertise.
Hi, Robert Green. This is a fantastic conversation. Thank you so much. I'm a big believer in polygenic risk scores, so not challenging you on that at all. But I wonder if you may have oversimplified by trying to reduce the monogenic conversation to just BRCA. Because by calculations I've tried to do, if you just take the ACMG list, for example, and you look at the genes that the monogenic genes that can put people at increased risk for breast cancer, which are BRCA1 and 2 and about 11 or 12 others, you actually may get to close to 1% of the population who have likely pathogenic or pathogenic variants in those. So I really think that a dual strategy here is important. I do think we're going to reach the point soon. I hope we reach the point soon where we can consider population screening. And the population screening could be for both monogenic and polygenic risk for breast and other cancers. So that's sort of more of a comment. And my question is, in all of this, I don't think I heard you talk about polygenic on top of monogenic. In other words, using polygenic to further stratify people who are carriers. And I think that's such a cool use case. I wonder if you could comment on that.
Yeah, it is a very interesting area, especially where I mentioned before you can have two BRCA1 carriers with very different risk. And part of that could be due to the functional location of the actual variant, but part of that can be the polygenic risk overlaid on top. And that is actually something that quite a few clinical trials are ongoing right now in that population to see if it aids in decision making. So if you have a high polygenic risk and you are a carrier, would you choose risk reduction surgery a little bit earlier? If your polygenic risk is really low and you're a carrier, or you're even a moderate penetrant carrier and not a BRCA1, you may not do risk reducing surgery at all, and you may just do active surveillance with the MRI. So it's a really interesting topic, and I think in the next few years that will be available on the market too. But I do agree a comprehensive option for the general population would make it easier, because we do know we're missing women that don't have the family history that are carriers. And it's an important risk to weed out, even though it's low. I mean, 1% low, but it's still, it's not, yeah, it's not insignificant. So to find that population and then to reflex everybody else to general risk assessment to help further stratify would be beneficial.
Hi, Paul Billings. I have a couple of comments and then a couple of questions. First comment is breast cancer occurs in men as well as in women. It's way less common, obviously. I think the data is that it's a lifetime risk of approaching 10% in women, 8 to 10% in the United States. It's maybe 1,000 to 10,000 times less common in men, but it does occur. And of course, in BRCA carriers, it may occur more frequently. Second comment is that if you look at the data from Myriad, LabCorp, Quest, Color, Natera, Tempest, and others, in terms of the volumes of hereditary cancer screening, cancer risk testing that they're doing, there are almost 1 million people who are getting these tests in the United States every year. So it's a lot of there's a lot of people who are getting this either a false reassurance that their risk is decreased, or getting, in some cases, incomplete, I think, information when they're given a risk categorization. And I think that needs to sort of be cleared up. My two questions are, one, I didn't hear once the term protective mutations, protective PRSs, and was sort of getting at the same question that Robert just asked, which is, are there BRCA positive or other germline positive mutations which are protected by your polygenic background? So your risk is actually reduced from some other polygenic background. And then I guess my second question is, in the group of women who are BRCA negative but are family history positive, is there evidence that they have risk for other cancers? Certainly we know that BRCA positive women have a risk for ovarian cancer, have elevated risk for, I think, colon cancer, certainly for pancreatic cancer. Is that true in the family history group as well?
Yeah, the family history question is interesting. So the polygenic risks are actually disease specific. So you could layer on multiple polygenic risks for other cancers and probably see something in the family history depending on what the family history background was, whether it was specifically breast cancer, whether there's prostate or pancreatic sort of mushed in there. And then layering on the different polygenic risk scores for all of these different cancer types because they're unique. They're not the same group of SNPs. But that is something really interesting because you can actually get a much bigger picture of an individual's overall cancer risk for multiple diseases than by looking at all these different factors and all their then clinical risk factors, the family histories of each of the different diseases and the way BMI interacts with each of those diseases. So they're really individual risk assessment models for each type of cancer. But it would be really nice to give that sort of at a GP level and then be able to talk about screening. And I forgot the first question. Yes, the protective. So yes, there are protective variants. There are SNPs that we incorporate. So it is interesting. And again, when we talked about the ethnicities, some of that protective nature is actually flipped depending on the ethnicity of a patient. And that does come into play, especially with a carrier and then the polygenic risk on top of it. You can really lower a woman's risk or increase it based on that sort of protective side. But I also want to say the polygenic risk, yes, we identify people on the high end of the spectrum and the low end of the spectrum, but even women at the low end of the spectrum, even though the risk is reduced, there are still some that develop breast cancer. So it's not zero risk. It's just lower than average risk. And I think that's something to keep in mind as well, because this isn't a yes or no, you're going to get cancer or not. This is a spectrum of risk, and it's sort of a sliding scale that can be changed over your lifetime. You know, every year your risk goes up just because of your age, which is the #1 risk factor of most cancers.
So what are your thoughts on the ethics of informing client children when the patient test is high risk for breast cancer with sex-linked common genomic markers?
Yeah, so common genomic markers are unique to the individual. So you can't, just because you have a certain risk doesn't mean your child or your sister or your brother is going to have that same risk. So they need to be uniquely measured, because you get, you know, some SNPs from your mother, some from your father. You have the recombination. You have a lot of things going on where you can actually have the polygenic risk be pretty different between you and your offspring. So it's good to talk about, but I don't think it's information that can be directly passed on.
Hi, excellent discussion. In full disclosure, I'm a genetic counselor, and I'm here at the Broad now, but spent many years working in an oncology clinic. So one of the sort of questions I have is regards to kind of the actionability of the PRS scores. And so we had the luxury in our clinic of being able to talk to women about their risk, to run their Gale models, their Tyrer-Cuzick, do a detailed family history. So I know I was very lucky to be able to give women that information. And we're very excited about the prospect of polygenic risk scores, even personalizing that further. But I think sort of the fear and hesitation we have is that we're gonna give that information back. A woman's gonna cross that 20% lifetime risk threshold, qualify for high-risk screening, but her Gale is stuck at 19%, and she might not reach insurance criteria to be covered for screening. So I wonder if you could speak to kind of where we are now with sort of the reimbursement and actionability of the recommendations that come from PRS, and sort of where we can go in the future from here to make that more accessible and actionable for patients.
Yeah, that's a great question. So what we've done with GeneType in this risk assessment model is, even though we love PRS, we think it's very cool, we don't talk about it independently, and we don't suggest that it's actionable on its own. So it's incorporated into a risk assessment model, and the model that we make is directly, all of our validation studies, we directly compare it to the Gale model and to the IBIS model and to other clinically recognized risk assessment models that are already in guidelines. So NCCN has a nice big chart of all clinical models that are recommended. We have compared it directly to those, and we show that it outperforms in terms of the calibration and the discrimination and its ability to stratify. And Hannah's put up this slide here. So in a healthy screening population, this is just some data from the Nurses' Health Study, a small case control subset. And in the control population, women over the 20% lifetime risk threshold, which is actionable by the IBIS model, which is standard in clinical practice, about 2% of the women are identified as at high risk. So 2% of the general population would qualify for additional screening based on their risk score. Using a risk model that incorporates polygenic risk into it and further stratifies that population, we're getting 10 times as many women. So 22% of the population actually should qualify and is pushed over the threshold. And your point about insurance coverage is a good one, and we're working on that and working on getting into the guidelines by showing that polygenic risk, yes, it's a great, cool tool. There's no mechanism of action. We're not talking about it in a sense of like a BRCA1 mutation where we know a functional consequence. Polygenic risk is a risk marker on an epidemiological level at this point, just like family history is and just like breast density status. And those risk factors are commonly accepted and commonly integrated into models already. So polygenic risk in the same way can be integrated, and what we're reporting out isn't a polygenic risk score. We're reporting out an absolute risk score that's already commonly accepted and has been for 20 years.
And to your point on insurance, because this is what I actually focus on, because this is actually what keeps this type of information from actually being able to be used by you, because you can't do anything about it as a genetic counselor if insurance won't cover it. And that is what gates a lot of this technology. But the economics for this, if you actually look at the implementation of a polygenic risk score like GeneType into the population, it's actually net saving. It's financial saving. And so what we talk about with payers is, I think insurance companies have tended to think of this in, discrete buckets. Like, this is going to cost me this many dollars today. And they don't think about it in terms of how much is this going to save me this year, next year. They certainly don't think about it in 5 years. But if you can show them the ability to impact downstream healthcare costs, that's the only thing they care about. And so that's really what is going to change the perception and enable the implementation of this type of information, is showing them that it's both clinically beneficial and economically beneficial for the payers.